I'd like to introduce someone who has been a mentor to me and guided me through 15 years of C4 and 26 years that I've been in the field. So, Dr. Norm Hoffmann.
Good morning. I kind of feel like Captain Johnson. General Grant had a captain who was known not to be the sharpest saber in the scabbard, and one of his colonels accosted Grant and said, "Why do you have Captain Johnson in the briefings for the battle plan? He's dumber than a stump." And Grant said, "No, Captain Johnson is very important, because when Captain Johnson understands the battle plan, everybody understands the battle plan." So this morning I'd like to cover some things that are from the perspective of the ground and how we look at things in terms of developing treatment plans and how we justify or support treatment plans. Now, a lot of you have heard of evidence-based practices, I'm sure by now, but there's a problem with that. Because first of all, evidence-based models are often developed in very rigorous, controlled environments. They have exclusion criteria, inclusion criteria, and the like that you do not have when you have a clinical practice. You have to deal with what walks through the door. There's a question of whether some of these models can be pragmatically implemented. And even if they are implemented, are they implemented with fidelity to the model itself? And there's no accountability in terms of verification of whether the outcomes are there or not. I like this one. One of the great mistakes is to judge policies and programs by their intentions rather than their results. And the problem with that is, with the evidence-based stuff, is most of the measures that are used to establish the evidence deal with issues of reductions in use. Now, there's another problem with that, as we're going to see, because use is not part of the definition of a remission in the DSM-5. Now, the outcomes that I'm seeing on some of these studies are not really that much different than what we saw in the old Cater system back in the 80s and early 90s. And there's also a problem of methodological rigor in these. Now, some of these studies use arbitrary metrics. An arbitrary metric is defined as a measurement that's reliably measured, scientifically valid in that it measures what it purports to measure, and it's irrelevant. In the addictions field, average days of use in the last 30 is an arbitrary metric, as are some of the psychological tests that we have. If your Beck Depression Inventory score goes down 2 points, are you now not depressed? Maybe, maybe not. But we really need to look below the statistics. Now, let's say we have two programs, Program A and B. They each treat 100 people. Before treatment in Program A, the average days of use is 25. After treatment, it's 10. Program B also treats the 100 people, has the same before days of use, and after treatment, the average days of use is dropped to 8. So which program is better? Anybody want to vote for A? Anybody want to vote for B? Anybody give a crap? No. Okay, well, let's look at the real world. In Program A, they were successful with 60 people. They're in sustained remission. 40 of them they didn't touch. Program B has 0 remission. They've all still meet criteria for a severe alcohol use disorder in this case, but they've confined it to weekends. So now which program would you send somebody to? So that's the effect of having arbitrary metrics. The other thing is we often assume that randomization takes care of everything. Randomization is really a substitute for knowledge. If we really knew what was involved in whether somebody is successful or not, we wouldn't need to randomize, we could match. So randomization actually is a substitute for a lack of information or a lack of knowledge. Many of the studies fail to account for services outside the research protocol. And in fact, when I was at Brown University, we did a survey of some of the excellent randomized clinical trials. and found that about 20% of them never even mentioned a diagnosis. They studied people coming in for treatment, but there was no documentation of all the other co-occurring disorders and anything else. Project Match is one that is often cited, looking at the difference between 12-step programs, CBT programs, and motivational enhancement programs. This doesn't really make a hell of a lot of sense to me, quite frankly, because if you have somebody in a 12-step or CBT program who is in denial and resistant, you might need motivational enhancement techniques to deal with that. Conversely, you might have somebody in a motivational program and a CBT program that are doing well, but they don't have a support system that a 12-step support system might provide. So trying to segregate things by these types of modalities really doesn't, to me, make a lot of sense. Now, other problems with the research are that they often ignore other kinds of prognostic indicators, and we're going to spend some time on empirically identified prognostic indicators. And we're also going to look at some characteristics of the individuals that are often also ignored. And the use of imprecise terms drives me up a wall. These are some definitions or some terms that you'll find in all the best journals. And we use these terms quite frequently without appropriate definitions. So I'd like to give you a few of those this morning. Now, a heavy drinker, that was easy. I knew what a heavy drinker was. That's somebody who weighs 250 pounds and drinks. I used to say I didn't know what a problem drinker was. I didn't know what that meant. And a counselor in Canada, actually, in Saskatoon, informed me that a problem drinker is somebody who spills more than he swallows. When I lived in Minnesota, one of my neighbors ran a liquor store. And he said, well, alcohol abuse, that's easy. That's pouring water in a good scotch. We really do need to become a little bit more careful about the terminology we use. The other one that drives me up a wall is the best practices. There is no best practice for everybody. If anything we've learned from all of the trials and things that have been conducted is that everything works for somebody and nothing works for everybody. And with regard to practices, it's what's the best practice for whom? And I have a colleague who once said that, well, if you had a program or a technique or whatever that was 100% successful with 5% of the people with a problem, is it a good program? And the answer is it is if you can identify those 5%. So we really need to become more sophisticated. And one of my other pet peeves is the mandates. Mandating evidence-based practices or best practices could also be called the Researcher Full Employment Act, in that you really have to be able to have the flexibility to make decisions about individuals, because we do not treat populations, we treat individuals. And so we need some flexibility in what we do. Now, when we talk about assessment, there are certain things patients really don't need. They don't need a superficial exam that doesn't really plumb the depths of the problems they have. We heard that on Sunday evening, that there are considerable considerations on opiate users and the like. The other problem is they don't really need an archaeological dig either. A lot of what people cover in the biopsychosocial interview would really be more productive and more relevant to the individual if it was done after intake. You know, the long-term history from beginning to end and that sort of thing. And also things that are not really on point of establishing a diagnosis and a treatment plan. So what do patients actually want? They want four things, in my opinion. They want validation that they have a condition that they should seek help for. In my part of the world where I live, the response for that might be, y'all done really good coming in here because you got something we need to treat. They want assurance that the condition is treatable. They want hope that there's a good chance that it's going to be a successful treatment. And they want an action plan that's realistic, logical, and acceptable to them. You know, we'll make sure you never drink again, but we're going to have to cut your right hand off. No, that's not quite acceptable to most people. What clinicians need are also four things. You need a diagnosis. Now, I always hear people talk about, well, I don't want to hang a label on anybody. But I think as we go on this morning, you'll see that coming up with the diagnosis and a more precise definition of the diagnosis or more precise delineation of the diagnosis is really critical to the treatment plan, because you really can't treat what you can't know. We also need to look at the severity of co-occurring conditions and the prevalence of other conditions. We're doing a current study in our local jail, and we're finding that PTSD is positive on about 65% of the people. So that has an implication for what these inmates probably need. We need to know something about prognoses. We're going to spend quite a bit of time on that. There are certain variables that are very powerful in predicting whether or not somebody's going to be abstinent 12 months from intake. There are 4 demographic variables, and you could be thinking about that. In the smaller group, I do it as the test for the morning of what are the 4 demographic variables that predict outcome. And we need an action plan. So clinicians also need the diagnosis, severity and complications, prognoses, and an action plan that meets the identified stuff. So what I have come up to term it is getting fit for MOATs. And I've discovered once you've got the acronym down, everything else falls into place. This stands for Flexible Individualized Treatments based on outcome and assessment-informed treatment strategies. So what do I mean by that? Well, first of all, it means we have to monitor outcomes. We have to establish a baseline and at least some rudimentary outcomes on all clients. And the first thing that I usually hear on that is, well, we lose track of some people. Well, that's an outcome. If the person doesn't come back for the second visit, that's an outcome. If the person doesn't finish the treatment program, that's an outcome. As well as, you know, the person's out 6 months, 12 months and doing just fine. That's an outcome also. The monitoring for this can be done during the normal clinical experience. And the information you need for doing outcomes-based treatment is probably 90%, 80 to 90% already in your medical records or your clinical records. We're not talking about anything new, and we're not talking about needing a tool or anything really super sophisticated or expensive to do this. The only thing you have to be able to do is retrieve the data so you can match your assessment data to your outcome data. So that's the outcome part. For the assessment, we need much more detail. A diagnosis, general diagnosis, as you will see, is not sufficient. We need more information about the specifics of what is positive about this person and what is negative in terms of diagnostic indicators. We need to know about the mental health stuff and the documentation of demographics. I just said there were 4 demographics that make a big difference. We need to know what they are. And virtually no program, I would wager, uses those 4 in making any clinical decisions in a systematic way. So again, with the assessment, we need to be able to retrieve that assessment information in a way that we can match it up with the outcomes. Once we match the assessment and the outcomes, it will tell us not only whether certain individuals or certain types of individuals are doing better or worse than others. It may also, if we do it properly and we match it with some service information, tell us where our program is strong or weak. It can also give us insights into how we might need to modify programs to become more effective. So this is the challenge that we've got, is that we have a wealth of practical information out there that is not being mined. And with electronic records coming onto the scene, we should be able to, if those are properly designed, get good information. Now, the key word there is properly designed, because I did a consult once for the District of Columbia. I was part of a consult for the district, where they had spent $500,000 on an MIS system actually in the corrections area, that from a statistical standpoint was totally useless because everything was put in string formats. That is to say, everything got typed in as words. And if you made a typo, you came up with a different value. So if you misspelled psychoses, you had 2 different diagnostic categories. So it has to be in a format that you can actually quantify and analyze. So the opportunity I think we have here is phenomenal with the electronic progress and with the DSM-5. I happen to like the DSM-5 for a number of reasons, and we'll talk about some of those. But I think the emphasis on quantification of the diagnosis is very important, and also the relative lack of a priori assumptions. One of the big problems with the DSM-4 was that it put some of the diagnostic criteria in the wrong category. Some of the stuff that was in dependence should have been in abuse, and some of the stuff in abuse should have been in dependence. So we had a mishmash from the get-go. And I think with the policy issues, with the Affordable Care Act and other things coming up, we're going to be looking more and more at documenting outcomes and understanding what's going on with outcomes. And I think providers and clinicians can capitalize on these trends to actually provide better service to their patients. I've changed my wording on that too, because I've come to understand, as some people have told me, that Walmart has customers, or consumers, lawyers have clients, and clinicians have patients. So the DSM-5 has 11 criteria, as I'm sure most of you know. The first 4 deal with your reaction to the substance. The second 4 deal with behaviors related to the use of the substance. And the last 3 deal with physiological and psychological implications of using the substances. Now, there's one caution here, and also the initial DSM-5 had 2 categories. The final one has 3. And the DSM-2, which was still around when I was in graduate school, had 1 page dedicated to addictions. The DSM-5 has 110. And from the DSM-2 to the DSM-5, there is no empirical evidence to support any of those diagnostic formulations for addictions. And that's true for the ICD-10 as well. There is no sound empirical justification for why 2 to 3 is a mild, 4 to 5 is a moderate, and a 6 or more is severe. Any more than the definition of dependence in the ICD-10 is empirically grounded. The one thing I do like too about the DSM-5 is the definition of remission. Sustained remission is a 12-month period during which there are no positive DSM-5 criteria other than craving. What's not in this definition is use. So this definition applies to the misuser as well as to the dependent individual who needs to be abstinent in order to achieve remission. So you have actually potentially 4 categories of remission. You can have abstinence with no problems. You can have some use with no problems, which would be appropriate for the hell-raising college student who met diagnostic criteria for a moderate disorder and now is moderating his or her use and not having any further problems. You could have the minimal number of problems, which would maybe be equivalent to a slip or a full relapse. So the definition of remission in the DSM-5 gives us a gradient of outcomes that we can use and a better rubric for determining whether or not a program has been successful or appropriate. The other thing I think we need to keep in mind is the difference between remission and recovery. Remission, as you've just seen, is very clearly defined and fairly precise. As I go around, when I ask any 5 experts in the addictions field to define recovery, I usually get a minimum of 6 definitions. And recovery usually encompasses a lot more than just recovery from the addiction per se. It involves getting serenity. It involves improving one's relationships. It may improve one's vocational capabilities and the like. My argument is that those things indeed are important, but if they're important, you should get paid for doing it. If it's important that somebody be employable after treatment, then you should get paid for vocational counseling. And we in the field, I think, have been somewhat remiss and gullible in that we've tried to do all these other things without necessarily being able to get paid for what we're needing to do or feel that we should be doing. So I'm going to be talking about remission, because that is the circumscribed thing that I understand at this point. Now, I like this. The truth is rarely pure and it's never simple. I mentioned before that we need more details because what we have found in looking at the data is that all the criteria are not created equal. Some of the criteria are almost exclusively found among the severe cases. Some are scattered all over. Some criteria are relatively prevalent even among those people who don't have a diagnosis of any kind. So we need to be a little bit more precise in what it is that's contributing to the diagnosis. Tolerance and use in dangerous circumstances, or use that is dangerous, are two of the criteria that are the sloppiest of the group. About 10% of the people who don't have a diagnosis in some populations acknowledge tolerance, because tolerance is a function of your use pattern, not necessarily of your addiction. And when we talk about dangerous use, there we're mixing in some other things, impulsivity, sociopathic tendencies perhaps, or other things. So here are two criteria that are traditionally, at least tolerance in the dependence or the severe range, but we find that empirically that doesn't hold up. What we find actually is this. These are the criteria that are almost exclusively found in the moderate to severe range of the DSM-5. And most of those are in the severe range themselves. Compulsions and preoccupations are actually one criteria in the DSM-5, but we've separated them because I think they are somewhat different. Setting rules that you fail to follow, failure to fulfill role obligations, missing work, not taking care of kids, whatever, sacrificing activities to use or because of use, and withdrawal. Now, the other criteria, not to say they're not important, but they're scattered. They're more indications of mild to moderate conditions than severe. And you'll see there they drop legal problems from the criteria because of serendipity. Some people get caught, some don't, and because they felt it wasn't specific enough to an addiction. But legal problems really don't look that much different than tolerance in terms of the scatter among the different diagnostic categories. So this is about 6,800 males. If we look at the gals, the women have very similar profiles, the same criteria that are almost exclusively up in that severe range are the same ones that we see in the men. The only difference is time spent using tends to slip up into that category for the women. And the other categories are also scattered, as they were with the guys. And the tolerance, again, is the one that's scattered about as much as anything. 10% of the people that don't hit a diagnostic criteria acknowledge some level of tolerance. So we've dubbed these the Big Five. Wanting to cut down and setting rules that you don't follow, craving or compulsion to use, failure to fulfill role obligations, sacrificing of activities to use, and withdrawal. Now, when I first started in the field, the old-timers kept talking about loss of control as the critical issue for an addiction. And I think these 5 criteria are compatible with that concept of loss of control. And I believe that, and I have to say believe because I have no proof otherwise, I believe that these Big 5 will be important in determining treatment plans. And also whether abstinence is actually essential for somebody to achieve remission. Now you notice remission does not include the word use. Remission is not having positive diagnostic criteria for a 12-month period other than craving. These other criteria, I think, are more indicative of mild to moderate kinds of symptoms. And what we need to document this is a matrix like this. So we need 11 columns, one for each of the 11 criteria, if we're going to use the DSM-5, and a line for each substance, or a line for each case. In this case, I've laid it out as cases, so that the first guy is meeting the criteria for severe, because he's positive on 8 of the 11 criteria. The next one is a mild, only positive on 3. And then we have 2 moderates. But the two moderates have different patterns of positive responses. The one on the bottom has more of those highlighted X's, which are big 5 criteria. So the question is, we have two people with the same diagnosis. Do we have the same treatment plan and the same prognosis? Let's take a look at that, because the first time I saw this sign, I thought there's somebody in the Department of Transportation needs an employee assistance plan pronto. But living in the mountains, you realize that we don't have roads like they do in Kansas and Iowa that go straight lines, perpendicular to each other. With mountains, you need to drive around the mountain. And where this sign is located, the road happens to go east and west. Okay? Because we're going around the mountain. However, a few miles down the road, the one goes south, the other one goes north. So the sign makes perfect sense once you understand the context of the sign and you understand why the sign is there and how it functions. So if we look at our case 3 here, this is a chap that spends a great deal of time in the bar drinking with his friends. As a consequence of that, he's developed tolerance. Occasionally he drinks more than he intends to because one of his buddies shows up and they have another. He has innumerable conflicts with his spouse because she complains about the amount of time he's spending at the bar instead of at home or doing something else. And after he's done drinking at the bar, he drives home well above the .08. So here we have a person with a moderate diagnosis. He has 5 positive DSM-5 criteria. However, there's no indication that there's a loss of control here. We have misuse and possible irresponsible behavior, definitely, in terms of driving drunk. But there's no indication here that moderation is out of the question. So if he spends less time at the bar, spends more time at home, occasionally takes his wife to the bar and parties, stops drinking alcoholic beverages after 2 and switches over to non-alcoholic beverages, and either stops before he hits a .08 or has his wife, who's now accompanying him, do the driving, we have resolved his problems. He will no longer meet any criteria, and eventually if he cuts down on his use, so his tolerance will also drop. Now let's look at case number 4. This chap has missed some work because of his use, decided he needed to cut down, tried it, found he couldn't do it, craving and compulsion to use. He still uses when he doesn't intend to, and he's sacrificed activities to use. This person also has a moderate diagnosis. However, we have a clear indication of loss of control. He's actually positive on 4 of the big 5, and I would wager he is not going to hit remission without abstinence. The beauty of the DSM-5 is that it gives us for the first time a criteria that allows us to begin to look at who needs abstinence and who might not. The big conflict between the moderated use folks and the abstinence folks might be resolved here because both are correct. Some people do not need abstinence to achieve remission. Other people do. This gives us a possibility of looking at who is who. So the DSM-5, I think, gives us some guidance in this regard in that anybody who hits, not anybody, 99%, maybe 99.9% of the people who hit severe diagnostic criteria on the DSM-5 will almost inevitably hit some big 5s in that process. So those with a severe diagnosis probably need abstinence. However, those with a lesser diagnosis may not. So those in the mild range, unless in unusual circumstances, probably don't necessarily need abstinence. Those in the severe do, and the challenge is going to be parsing out those people in that moderate range, as we just did. And there, the pattern of positive responses is more important than the number. So we don't need to just put down a diagnosis. We need to know which of the criteria are actually positive or not. Because that moderate range group is the one that's going to give you the most difficulty in distinguishing between those people who definitely need abstinence and those who may not. Now, the DSM-4 wasn't very good in this regard because you could get a dependence diagnosis like that first fellow would meet dependence diagnosis because he had tolerance, he spent a lot of time drinking, and he occasionally drank more than he intended to. That would get him a severe diagnosis. But we also see that failure to fulfill role obligations, which the DSM-4 put into abuse, is actually a more serious criteria and should have been over in the dependence category. So by artificially segmenting what's abuse and what's dependence in the DSM-4, we got a lot of confusion so that a lot of people who would be called dependent maybe wouldn't fit into the DSM-5 criteria for those people who need abstinence. Conversely, some of the people who might have been abusers were really early on cases that were going to go on to bigger and better things in terms of their substance use. So here we have some potential hypotheses that you can come up with. The first one that I just put together was if anybody has 3 or more of the big 5, they'll require either a residential placement or a more intensive placement. Now you ask, where did I come up with needing 3 out of 5? Well, I use the tri-monitored method of DRE, direct rectal extraction. Hypothesis 2, that one takes a little while to ripple down, doesn't it? Hypothesis 2, just for the heck of it, is if you have a mild to even a moderate with no positive findings for the DSM, for the big 5, that they will be able to moderate use. So these are things that you could check out in your clinical practice. And either verify or refute. They say a good hypothesis is one that can be easily, or good theory is one that can be easily disproved. So have at it. But I think on a more serious note, what this does is it gives us, I think, for the first time, some really good empirical foundations for establishing clinical or medical necessity. In the past, medical necessity was pretty much what the insurance company dictated. But I think now we have the capability of looking at empirical data. And if you can demonstrate that people with this profile who do not get these services do not have the kind of outcomes that we would like to see, you have the capability of arguing the case that the definition of clinical or medical necessity should be altered. Now, I think each treatment plan can be informed also by the results of prior findings. So we have here a method by which we can incrementally improve what we do and provide the evidence for why it is we're proposing to do things differently, rather than, well, I think it really ought to be this way. Well, what you think and what you can prove may be 2 different things. I once had a meeting like this, was sitting with somebody when we were doing the CATER system on doing outcome evaluations, and the treatment director said, well, what have you found out so far, Norm? And I told him some of our findings, and he said, you know, you haven't told me a darn thing I don't already know. I said, yeah, but I got the data to prove it, do you? He thought about it for a minute and says, I'm beginning to understand the value of what it is you're doing. Now, this more sophisticated approach or detail to documentation also applies to co-occurring conditions. These are the 5 basic criteria for PTSD, with the subcategories for each one. So there are 4 ways that you can experience a traumatic event. You can experience it yourself, you can see it, you can hear about it, or you can repeatedly see the after effects of it, like a first responder might have something in that range. So, and the rest of the criteria also have specific things about, you know, intrusive symptoms and altercations or arousals and reactivity. So Here too, we might find that it's the pattern of positives that are important, not just the number. And we might find that there's a severity gradient in PTSD that we can define by looking at the diagnostic criteria themselves. Now, I'm not a PTSD expert, so I don't know that yet. But what I do know is that these 24 variables from A to E, if each one of them is coded positive or negative, will give me a very detailed profile of PTSD. If I don't want to drill down that far, I could do the totals to see a more coarse-grained view of severity. But having something like this, either the number of positives for each one of the 5 or the actual yes-no for each one of the specific criteria, will give me a lot more definitive information about the nature of PTSD in a given individual. So the kind of detail we're talking about is not necessarily rocket science. It's not necessarily going to, overburden your clinical record, but it will give you a lot of information that you don't now have if all you have is the general diagnosis. Now, a lot of what we're talking about so far has been focused on the DSM-5. We get a lot of the same information, or a lot of the same principles will also apply to the ASAM patient placement criteria, or the ASAM criteria as they're now known. So we can identify other kinds of relapse risk factors in dimension 5. Dimension 5 of the ASAM criteria is the one that deals with risk. So we have dimension 1, which deals with intoxication withdrawal, dimension 2, which is physical conditions, dimension 3, the psychological, psychiatric conditions, dimension 4, readiness to change, dimension 5, which is risk factors, and dimension 6, which is the recovery environment. So the diagnosis and the ASAM criteria will give us case mix. Case mix is the description of the population served. For example, a program that serves physicians and other professionals, would it be expected to have a higher outcome rate than a program that serves homeless veterans? So the case mix in those two programs is going to be drastically different. It influences the type, duration, and the scope of services that need to be provided. It also, the case mix frames our expectations. And so dimension 5 on the ASAM criteria is a big piece of case mix, along with the DSM-5 diagnostic profiles. I mentioned the 4 demographic variables. If you're less than 25 years of age, no high school degree, no job, no spouse. Those 4 criteria, those 4 characteristics, those 4 demographic characteristics make a huge difference in expected outcomes. This is a published study that shows that the high-risk people with 2 or more of those 4, don't do nearly as well as the people that have 0 to 1. On a little bigger sample, I don't work with small samples, 13,000 in this case, you can see the difference between the people who come up zip and the ones that have all 4. So we go from a 65 to around a 25. So we're talking about a 40% differential in expected outcome at month 12. Think about that a minute. 4 demographic variables in a huge population looking across all kinds of diagnoses and all kinds of situations can identify subgroups of patients that range from the odds that most of them are doing well at 12 months to very few of them are doing well at 12 months. When we look at whether they're inpatients or outpatients, we find that there's no significant difference between the 2. So that the 4 demographic variables are not being used by programs in making placement decisions. There's a little trend that the ones with fewer risk are in the outpatient programs and the ones with more risk are in the inpatient programs, but it's not really significant at this level. Statistically, You'd be well beyond 0.05, obviously, because with 13,000 people, anything that's not significant at 0.05 is significant. But when we look at outcomes, we do actually get significance in that the people at the low end actually do better in outpatient. The people with the higher severity or the higher risk factor do much better in residential programs. So while these factors are not related to placement and apparently probably not related to treatment planning, they do have a tremendous implication for what we would expect to find. So these are variables we need to think about. How many adolescents fit these 4 variables? Anybody out there? All of them, yeah. This tells us why you cannot treat an adolescent on average with the same resources that you can treat an adult on average. Adolescents are going to take more services, more intensive services, more frequent services than adults. Also, if you have a program that's serving young adults, you may have a longer road to hoe than you thought. So 4 demographic variables, and these have been found consistently over the years. They're also they're documented in various research that has actually looked at risk factors. They've been found there consistently. And unfortunately, most of the research that's been funded by the feds has been horse races between, program model A and model B, and has not looked at the issue as a primary focus of who does better with which. And nobody, to my knowledge, has really looked at why somebody would do better with one type of program than another. Now, here's a clinical risk factor that comes from the same database. Having 2 or more dependence diagnoses, these data were collected in the era of the DSM-4. Frequent use or multiple use just prior to admission to the treatment program, 2 or more substances used in the week prior to admission. Use of a needle. Needle is important. I don't care what the substance is, but anybody who's sticking a needle in his arm to get high has crossed a threshold that some people have not. And what we saw in this database, at least, was that needle use increased your relapse risk by 10 percentage points, just like that. And again, unlike some of the requirements where you have mode of ingestion for each substance, I don't care what substance it is, if somebody is shooting something up, that's a criteria. I once worked in a facility or a hospital that had a physicians association attached to it of about 250 doctors in various specialties. And the family practice folks did the medical coverage for the jail in St. Paul, Minnesota. And they caught one inmate trying to shoot up ketchup. It was the only thing he had, but he was going to try shooting it up because shooting up worked for him. We see the same pattern, and we've cut it off at 3+ in this case. Same pattern. Now we're seeing with the clinical stuff, there definitely is involved in making placement decisions. The people with the low severity of the clinical scale get into outpatient much more frequently. The ones that are really high, much more into the residential program. So this is significant. And we don't see quite as much of a difference here. And that we have this anomaly at the end that the few people that are in this one cell seem to be doing very well in outpatient for some reason because they must have something going on with them that the others don't. But there's just a trend there rather than the marked thing we saw before. So for the clinical risk, we still have the same basic pattern. There's a general superiority for residential at the high levels. The outpatients actually do quite well. The IOPs do very well at the low range and the like. But the clinical risk scale doesn't seem to do as much. Why would that be? Well, one possible explanation is that if you can take the risk factor into account and adjust your treatment program to deal with the differential risk, the association between the risk factor and the outcomes will disappear if you're successful. So it may be that the programs with the clinical risk factors are adjusting their treatment plan so that they are compensating for the differential risk, while with the demographic risk factors, they're ignoring them, and so the relationship between the demographic risk and outcome is much greater than it is for the clinical risk and outcome. Because if you all go home now and start looking at those 4 demographic risk factors and start adjusting your programs to compensate for the relative risk, then the next time we do these data, that relationship will be less. Are you following me with that? Is anybody paying attention out there? So, by looking at greater detail in the assessment process and marrying that with results during the normal course of treatment, because we also know from all the research that the treatment continuum should extend at least 6 months from intake to the end of scheduled visits. We know that's a minimum. And anything that has a continuum of less than 3 months doesn't do much at all. So we know from the research that we have a continuum of care that we should be delivering and should be paid for to produce reasonable results. Now, this is what we see when we combine the demographic and the clinical. The lines are the demographic risk factors. The clinical is the horizontal risk factor. So even at the low clinical rate, the demographics seem to be more important. Because these lines are relatively parallel, it also tells us that the demographic and the clinical risk factors are relatively independent of each other. They're providing a different source of variability. But also because the demographic and clinical risk factors are independent, in some cases they start canceling each other out, so we don't see the same kind of dramatic impact on some cases as we might expect. Now, if we look at length of stay, which is often a sore point for many people, and here we have the red bar at the bottom are those people that got less than 21 days, and the bars at the top range from getting 21 days to getting 30 plus days. Notice where the split is? Anybody who qualifies for a residential program and doesn't stay for 3 weeks has a lower probability of being sober at 12 months. I have empirical documentation that a residential stay should be 3 weeks. It's not 4, but it's 3. And this is something we saw all during the 80s and early 90s, that the cut point was at about 3 weeks. It's actually 19 days is the critical differentiating point. This is one of my favorite quotes from a professor I had when I was in graduate school. If your theory conflicts with folklore, recheck your theory. If your theory conflicts with folklore, recheck your theory. Because folklore is based on an observed association. The explanation may be fantasy world, but the association will be real. Remember I said you needed 3 months of contact time for anything to happen consistently? How many days in 3 months? 90. 90 days. Does that ring a bell with anybody? If your theory conflicts with folklore, recheck your theory. I can actually give you logic for why 90 and 90 works, why missing meetings in 90 and 90 increases your risk for relapse, why Meetings work for one person and not for another. And I can explain all of that with B.F. Skinner's operant conditioning principles. Reinforcement schedules and decay curves for reinforcement can explain why bottoming out was important in the early days, why going to meetings was really great for somebody and not for another, and why missing meetings increased the risk that the person was going to relapse, all based on B.F. Skinner and operant conditioning. If your theory conflicts with folklore, recheck your theory. So, we have all kinds of risks, and we have documentation of the amount of services that might be required, and we have now an empirical foundation for saying why we need to do what we're going to do. When we look at the outpatients, we see that something around 65 contact hours is a threshold. And again, we see that little anomaly at the bottom there that I'm not sure what's going on, if it's a statistical anomaly or that the people with high risk who wind up in an IOP have other compensating factors that are going on at that level. I have no idea what's going on there. But what I do have fairly confidence in is the fact that there's a threshold at all levels of severity that there is a tincture of time required, or a contact amount, or a dosage, if you will, that is required to achieve a reasonable result. So just like there are certain dosages for methadone maintenance that are required for people to stay clean from heroin, there seems to be in the abstinence-based program some dosage requirements as well that we need to look at. In this case, it's in terms of contact time, and also that would span some duration as well. And again, as with the residential program, we begin to look at how we're going to marry these things together. So we have demographic and clinical risk factors that we need to consider. We have other things, I'm sure, that are not in my database that we maybe ought to be looking at, because the addictions also are a movable feast. In that first slide you saw was a slide based on the DSM-5 criteria, was a sample of state prison inmates. And when we collected that data, alcohol was king of the hill. It was from Minnesota. The most prevalent substance of dependence was alcohol. We're currently doing a study in our local jail in North Carolina in Haywood County. It's a rural jail. Haywood County has about 55,000 people in the county, about 7,000 people in Waynesville, where I live. And we are systematically interviewing inmates from the jail using the CAPE 5 to look for addictions and co-occurring conditions. And what we've found so far in the first 40 cases is that 45% of the local jail inmates are regular injectors. 50% meet severe diagnoses for meth, 50% meet severe diagnoses for opiates, often both together. About 60 to 65% come up positive for PTSD. And depression is down there at about 30% to 40%, which is the one that most people talk about when you, co-occurring, depression. Not in this population. So this is not the kind of population that we used to see before. So the addiction field is a movable feast. And it's only the ability to marry your assessment information with your outcomes that can help you stay abreast of that. We heard on Sunday that, you know, the reimbursement stuff is going to change drastically. The only way you can really keep up with that, I think, is to get fit for modes. You have to be able to come up with flexible, individualized treatment based on outcome and assessment, identified or informed parameters. And then you can get your ducks in a row and also justify your placements and things like that. Now, let's look at treatment planning from another perspective. Let's go to the ASAM criteria and look at what we've got there. Let's look at dimension 4 and dimension 6. Dimension 4 is readiness to change. Dimension 6 is the recovery environment. So these are just 2 of the 6 dimensions on the ASAM criteria. So here we have case 1, heavy duty denial, very resistant to anything that he needs to do in treatment. I'm using he, could be she, and no realistic commitment to recovery. However, the family is very supportive, spouse is very supportive, best friend is in recovery, would be willing to be engaged in this process. So the treatment here, to treatment plan, we need some heavy duty MI, some motivational interviewing as a priority, and also we want to explore how we can maybe draw the family into engagement in the treatment process, what kind of resources they might bring to bear to help us with this person. So that's case 1. Same level of care now. Case 2 is good to go. Highly motivated, understands the condition, engaging in peer support groups, dynamite. The whole social networker, drinkers and users. Girlfriend is addicted. Brother is a dealer. Couple of family members need to be in treatment themselves. We've got a different treatment plan here, folks. Here we're dealing with strategies on dealing with the old neighborhoods and friends and how to deal with family and other individuals. In this case, a lot of the treatment strategy might be helping this individual get the heck out of that toxic environment and how not to get sucked back into it. So you can have 2 people in the same treatment program needing a very different treatment plan based on the assessment that you can make very readily in doing your ASAM criteria. So again, just like the diagnosis, the information we get out of those 6 dimensions of the ASAM criteria can guide us in what we need to do and also justify the treatment plan. Because I keep saying justify, because as we get under greater and greater scrutiny for producing results, you're going to have to be able to have the backup or the justification or the support for the decisions that are made. And if that information is appropriately collected by you, you will be in a very strong position to argue your case. So there are other things that you can do with this data that don't necessarily pertain to the treatment plan per se. Now, you don't need rocket science and you don't need a tool. This is a very simple scale of, have you used anything in the last 3 months, 6 months, whatever your time frame is. So we have substance use, longest period of abstinence. I designed some tools for the NAATP for their pilot outcome study, and we're looking at 3-month intervals for outcome for 2 reasons. One is a 3-month outcome from intake gives us an initial idea of whether things are doing okay or not. And also using 3-month rather than 6-month or longer intervals makes it more likely that you're able to stay in touch with people over time. And then you need something like this. The first set of items there are the uncope. The first 6 are uncope items. And the uncope can identify severe substance use disorder with about a 90% accuracy. 6 items. That's all it takes to screen for an addiction. So we just put the screen in as a means of looking at whether or not the person is likely to have problems, and then we added a catch-all at the end of any other negative problem that might catch any of the other criteria. The beauty of the uncope is the first 5 items cover 5 different DSM-5 criteria. So with that, and then we have what's the person doing during the outcome? Is he still engaged in aftercare or maintenance care? Is the person taking any medications? If their medications are indicated, is the person getting any other services? Is the person attending self-help groups and the like? And with that information, we can come up with something like this, based on what you're going to do in maintenance. Now, oncology has been doing this for years. Oncology has been doing this for years. I have a case in point. A woman had stage 2 breast cancer, had double mastectomies, and the conversation after surgery went like this. Well, ma'am, the odds that we got it all with the surgery are about 50-50. That's your survival probability. Now, if we do the chemo, you'll get pretty sick for a day or two, once every 3 weeks, for the next 6 months. If we do the chemo, your survival probability is 85%. Do you want to do the chemo? I know of another woman that had colon cancer. Her numbers were 75% and 85%. And she said, for 10%, I'm not losing my hair. Both women won, by the way. They're both still with us today. Oncology has been doing this for years. If you get out of treatment, don't do anything more, 50-50 that you're going to be sober in 12 months. Do a little, proves a lot. You do at least 6 months of maintenance care, 75% probability. Do you want the maintenance care? Oncology has been doing this for years, for decades. Decades. We can do the same if we collect the reasonable, credible information. I had a treatment director who had this slide and a couple of other ones, like the one on length of stay that I showed you earlier, because we put out little fact sheets on our results during the 80s. He says, you know, I really like your fact sheets. Now, he'd never used my service, but he used my fact sheets. He says, my out-of-pocket receivables went from $8,500 to $85,000. Because when I show people what their insurance covers and what they really should be getting, they buy the difference. So your outcome information can help people understand and be involved in. We talk about patient-centered therapy and patient-centered decision-making. Really involve your clients, your patients. Almost slipped there, didn't I? Lawyers have clients, we have patients. It can help us empower the patient to make decisions in their own best interest based on their criteria of what they think is important. I like this one too. For every complex question, there's a simple answer, and it's wrong. Keep that one in mind during this election year. We did this study on older alcohol-dependent individuals, and we found something interesting. For the ones we classified as low severity, if we got them into AA, they did fairly well. But for the high severity cases, if they didn't get the professional services to go along with the self-help group, things didn't work very well. So we can't be too simplistic in informing patients about what their odds are. In this case, it was an issue of you really need that 6 months of professional services, and obviously you do best if you get both the self-help as well as the other services. So what we're looking at is this. I adapted this from Dr. David Mealy, because I only steal from the best. I only cite the best. But basically, we're doing an assessment that informs the treatment plan. The treatment plan then dictates the treatment, or informs what is actually done in treatment. If that is not going well, then that should come back and adjust the treatment plan. The treatment response and progress then has a bearing on what our longer-term outcomes are. And based on those outcomes, that might influence how we do our assessment or how we adjust our treatment plan. And also, if we're finding out things looking at the treatment response initially that we missed, then that might, again, inform how we do our assessment up front. So this is a total quality continuous improvement model. This is Deming for the addictions field. Deming is the guy that came up with continuous quality improvement, which took the Japanese automakers from producing junk to producing cars that were kicking the American automakers' butts in terms of quality and breakdown events and stuff like that. So this is the model that will enable us to stay ahead of the game. And if we can put this model in with strategies for how we do reimbursements, then I think we will do well in the future. So the way forward, I think, is in outcomes and assessment-based treatment strategies. That we need more detail in our assessment, we need more documentation to verify what we're finding, and we need to monitor what happens to everybody who walks in the door. And if we do that, and you can all do this yourselves, it's not going to require a tool, it's not necessarily even going to require a consultant. Excuse me. What it does require is keeping detailed records of the information that's important in documenting what's going on with your patients and monitoring how your patients are doing. And your first outcomes are during treatment. You know, if you're not engaging at least 80%, there's some problem from intake to engagement, or the first assessment to engagement. If you're not getting an 80% completion rate, then you might want to look at why is that lower than that? Because there were programs back in the 80s that were getting 80% retention rates through treatment. Now, again, it depends on your case mix. If you're dealing with homeless, indigent individuals, you're going to have a tougher time hitting certain benchmarks than if you're dealing with airline pilots and physicians. But taking that into account, you can then begin to adjust and understand if your performance of your program is what you expect it to be or not. And that is the end of my formal presentation. I will entertain whatever questions you may have. There must be questions. I'm a psychologist. I'm not that clear. I have to be obtuse to some extent, so there must be questions. Yes, ma'am.
I was just wondering if you're, when the people are in outpatient, are they also in sober living?
In this database, no. Some might be, but very few would be in sober living situations, the outpatients. The question was whether the IOP patients were in a sober living environment or going back to their own homes. And in this database, at that time in history, most of them were going back to live with wherever they were living before. A few were not. There was one program that was innovative at the time that they contracted with a local hotel that did not have a bar they contracted for a block of rooms that people could stay at for a fairly reasonable price while attending the IOP because their insurance didn't cover the residential. But that was a very rare case. There was another, way in the back?
Norm, you had two slides that demonstrated the relationship between continuing in self-help groups and continuing in continuing care, which showed that the more you did, the better and the outcome was better. My question is, how much of that could be an artifact of the patient's motivation?
Okay. It could be an artifact of motivation to some extent. During that time, I think it was more an artifact of what the insurance covered. But I can't negate that it might be an artifact. But even if it's an artifact, I can still say to somebody, if you go 6 months of aftercare, we're seeing this result. If you're not, we see that result. Now, we may not know exactly why that is the case, but it would seem to me that staying engaged in the recovery process was definitely associated with, if not caused by, that association, that continued engagement. So even if we don't know for sure what the causes are, we can still give people information that this is what we see. You don't do anything, 50%. You do this, 75, 80%. Make your own decision. Yes, sir. Oh, ma'am. Oh.
Thanks for a great presentation, Norm. I was curious about what measures you're using for verification of outcome.
Yeah, sorry.
What measures you're using for verification of outcome?
Excellent question. How do we verify outcomes? We had one contract with a company that said, we want you to have collateral information on all of the clients that you're following for us. We followed 625 pairs of patient and significant other. And we found that the agreement between the two was typically 85%. That if the patient said he had used or she'd used, the collateral also said that the patient had used. If the patient said they had not used in the 6-month period, the collateral also did. The interesting thing was for the 15% that were different, 10% were cases where the patient claimed to be sober and significant others said they had used. The other 5% were the opposite, where the significant other said, I think he's straight, and the patient said, no, I had a slip. What we have found is that if you ask specific point-blank questions, and this is true for the diagnosis as well, that you tend to get specific point-blank and quite accurate information. As soon as you venture forth into that realm of subjective judgment, all bets are off. So if you ask whether you have done something or experienced something specific, you tend to get pretty on-point answers. As soon as you ask the question of how bad is it, or is it better now than it used to be, you get all kinds of garbage. So a lot of it is in how you frame the questions as you're going along and collecting this information. Other questions?
I have 2 questions back here, back of the room.
Okay.
Number one, a lot of your initial presentation seems similar to the findings of the RAND study done in the late 70s. So the question would be why it's taking so long for the field to incorporate those types of findings. Number 2, it seems that many treatment providers design their treatment programs based on expediency for the program and not individualized to the patient. What advice can you give the programs how to cost effectively do individualized treatment?
Why it's taken so long? Tradition, in large part. Another part is I think not understanding the real dynamics. I spent 5 angry years wondering why the insurance companies were not beating a path to my doorstep because I could document all this cost savings from what we were doing. Until I finally had the epiphany that for the insurance company, the only thing that mattered was premiums exceed payout, period. Whether your treatment worked was irrelevant. It was premiums and payout, that was it. And I think for a lot of programs, they didn't see the connection between doing more detailed diagnostics and documenting their results and whether or not that meant that their beds were full or their slots were filled. They didn't see the connection. When we were running the cater system, it was interesting to me that this was not necessarily a cheap contract. The typical contract was at least 10 grand at a minimum and usually went up to 20, 25. And where the money came from was interesting because most programs paid for the cater system out of their marketing budget, not out of their quality control or anything else. They paid for it out of their marketing budget because they figured it was going to be a marketing advantage. So I think the reason this hasn't caught on or people haven't done this before is first, it's different, and second, it takes a little more work to collect the information and keep it this way. And if it takes a little more effort, why do I want to do it unless I can understand the benefit of it? So I think it's getting it to the benefit of it. The other thing that the industry has done for a long time that I think has been a waste of time is we've spent a lot of time going to Washington and having, events on the Hill and that kind of thing, when we should have been sponsoring events for larger employers on the endpoint benefits of treatment for your employees. Because it's the endpoint payer who really has a vested interest in your treatment succeeding. But it depends on the endpoint payer. The fast food industry is not probably a good place to start because they typically don't have an employee that lasts more than 6 months. On the other hand, if you're running a railroad, it takes you about $250,000 in 3 years to get somebody qualified to run a train. So employee retention can be a real issue in keeping some of those guys on the job. So if you're talking about employers that have a workforce that's expensive or difficult to replace, you have an audience that's receptive to understanding the value of what you do and likely to help pay you for those little extra things that are more likely to keep people on the job and functioning well. So that's why I think it hasn't started before. What it takes for programs to actually do this, I don't think it's that much. It just takes a change of mindset. I think many clinicians, once they get the diagnosis, then that's all I need, and now I'm going to dig into the treatment plan. And I think we just simply need to think about, we need to look in greater detail about what it is we're finding, just as in other areas of medicine, we need some detail of what condition we're looking at, exactly what kind of tumor is it that we're dealing with, or what kind of cancer is it that we're dealing with, because you can have a lung cancer that shows up on the spine. So we really do need to be a little bit more precise in what we're dealing with. But I think the payoff is really there too. Other questions?
Norm, David Mealy back here. So back in the room. I think your case examples about dimension 4 and 6 were an example about how to do individualized treatment. And your point is well made that a person can be in the same level of care but have a different treatment plan. I would also say, though, a person can be in the same level of care and have a different length of stay. So my concern about your statistical correlations about if you meet the criteria for residential and you need 3 weeks, I think that can be true in a statistical population. But just like you were saying about evidence-based practices, we have to apply the evidence-based practice in an individualized way, and I think we have to apply sort of statistical data in an individualized way. So my concern is that if somebody thinks this person meets criteria for residential on day 1, it isn't automatically that that person needs 3 weeks to get a good outcome, because it depends on why you're in that level of care. As your nice case examples showed, if somebody gets into residential because they're having a lot of craving and they have a lot of difficulty stopping that right now, they need to be contained, but they actually have great readiness for change on dimension 4 and a great support system, and they've been in AA for 10 years, they just need to get back to their group. They don't need to stay there for 3 weeks to learn about addiction and recovery. So I think that's an important distinction about statistical correlations for a population versus individualized treatment.
Right. Well, we have to always be careful with averages, because if I take this hand and shove it in the freezer and I take this hand and shove it in the oven, on average they're comfortable. So your point is well taken. You treat individuals, you don't treat populations. The statistics simply give you the overall zeitgeist of what you need to look for. So for example, in that second case where the guy is living in a toxic environment, given everything else that's going on with him, if he gets into a sober living environment away from that familial and friendship network, he might be able to go out in a week. He might be able to go out in 2 days, But so that there is going to be tremendous variability as you're treating individuals, but it still speaks to the issue that we need to have precision in the assessment and in developing the treatment plan, because you have to be able to provide that individualized flexibility in order to meet the needs of the individual in a way that's also economical. Because I think in the long run, you're going to be looking more and more at capitated payment systems, where you're getting paid the average, and then it's up to you to figure out who needs the more and who you can get away with the less. Yes?
Hi, Dr. Hoffmann. Thank you so much for your presentation. I have a question. Are you aware of any outcome-based studies that correlate the level of financial investment that comes from the patient, him or herself, to overall outcome? My theory is that if there's some skin in the game, that there should likely be a better outcome, but I don't know of any formal studies that have measured that. Are you aware of any?
I can't cite you citations, but I do believe there have been some studies along those lines. But again, the simple answer is not the correct one, I'm assuming. I think it's a blend. Yeah, I think somebody who has a little skin in the game is going to be more conscientious. I have a mentor, E, that I counsel that anything free is worthless. And he took it to heart, because when somebody approached him to do a consult, he charged. But by the same token, I think there's also a threshold where the economics deter people from getting additional services. So a little skin in the game versus more than you can afford will have a bearing on whether or not the individual, whether the economics play a role in the individual situation, or whether it's positive or negative. Yes, sir.
Hi, Norm. Great presentation, thank you. The presentation the other night dealt with the haves and the have-nots, and I think that was the takeaway for a lot of people based on current neuroscience. The data that you showed from the outcome studies was, I believe, 1996. So my question is, what was, of the sample that you had, what was the subset basically for opioid dependence?
The sample I had for opioid dependence was negligible.
Okay, so what I am, and that's what I suspected.
That's why I was saying that this is a variable feast. When these data were collected, alcohol in the correctional population was the number-1 drug. Okay. What we're seeing today is it's nowhere near close.
Okay, so what I'm saying, not all a lot of people, the abstinence model has been in effect for years and years, obviously, since 1935. And my only concern was that a lot of us like to adopt what we're already doing. Mm-hmm. And so if this data illustrated brilliantly, a lot of people would walk out and say, well, if the distinction hadn't been made on that it was an alcohol sample, the cohort or whatever, the sample that you're doing was alcohol as opposed to opioids, then really what it was in direct contradiction to the data that was presented the other night in terms of the haves and the have-nots and the variability and the length of treatment. And I just wanted that to be addressed and clarified. Thank you.
Right, thank you. Yeah, if we'd have had the data on the haves and have-nots and their various brain chemistry levels, this information might look totally different. But I think the same principles still apply. We still need to gather the data, whatever it is, in as granular a form as we can. The analogy I like to use on that is, if you give me a dozen eggs, I can make any size omelets you want. But if you give me an omelet, I can't figure out what necessarily how the eggs go into that, other than volume. So I think the principles still apply, that with the opiates now and with some of the techniques and capabilities we have, we will be able to do much more. The kicker is when it gets to be practical to do it in real life and real life situations. So while DNA sequencing may tell us a lot, for example, now on any range of illnesses from addictions to cancers to whatevers, but DNA sequencing for a treatment program working in the inner city is not practical. But at some point, some kinds of tests may become practical, and at that point, hopefully, we will begin to use them to look at differential risk factors, to look at differential needs and things of that nature, and to maybe be more precise in figuring out the haves and the have-nots as far as the dopamines in the brain. So my point is that it's the technique that we need to employ, not the actual numbers or even the actual variables. They may vary a lot too. Other questions? Yes. Just a second, he's coming with the mic. I don't want to make you repeat.
Thanks. I have an outpatient clinic, and I was curious about the variable you were talking about, the 65 hours of contact, and that improved the abstinence after 12 months.
Pardon?
In an IOP, the abstinence after 12 months. The 65 hours you said.
The 65 hours, yeah.
Is that, does that have to be consecutive? Is that by the, because we're an outpatient, so our IOP is like, could be 3 times a week. Does it need to be consecutive?
It was variable. The contact time, what we did was we added up the total. What was the total number of contact hours, whether that was, 6 hours a week for 10 weeks, or whether that was 10 hours a week for 6 weeks, it was...
Makes no difference.
We didn't have any finer grain
Okay.
delineation on that. But what I was just doing with that was illustrating the fact that if we keep track of also our service units delivered, we can begin to really fine-tune medical necessity so that we can document, we need to have this much time to work with these people, because if we don't have that much time, then things don't go as well.
I'm curious, I really liked your high-risk description and the demographic and the clinical risk. Where would suicidal ideation or homicidal ideation fall into an evaluation of high risk, in your opinion?
Suicidal and homicidal ideation would fall into dimension 3 of the ASAM criteria on violence risk. On the adults, I didn't have any data on that. On the adolescents, we do have data from the PADI, the Practical Adolescent Dual Diagnostic Interview, on suicidality and homicidality. And the prevalence of suicidal ideation and even suicide attempts among the adolescent populations, both in juvenile justice and in treatment populations, is alarmingly high, as is victimization, physical, sexual, and emotional abuse in adolescent populations in particular are quite high. And also, unlike in adult populations where that kind of abuse may be more historical, with adolescents it's usually current, very current. But in the adult populations, I don't have any data on that.
Thank you, Dr. Hoffman. I have a quick question. So much of the data, much of the outcome research you presented has been done with, primarily an alcohol abuse population. Can the outcomes, the research outcomes be extrapolated to drug-using populations?
Actually, these populations, the main substances were alcohol, cannabis, and cocaine. So there was a significant proportion of individuals with those other substances as well. We have done some research on the diagnostics, and the diagnostics I shared with you about alcohol and the big five, those hold up for cannabis and cocaine as well. And we'll see how they hang together for the other substances, as we're seeing more in the opiates and the meth and stuff. But I think so the general principles of monitoring this are the same, but we will see some differences, because I'm quite frankly shocked by the level of injection use in a rural jail. I wasn't as shocked by the meth, because they're cooking meth in every cove in western North Carolina. And the biggest problem that the sheriff has is finding all these darn meth labs. So the meth didn't surprise me as much as the opiates did. But I think, we'll need to keep track of that and see what, how we can parse it out, and whether some of the stuff that I showed you holds up for the other substances or other combinations. Mm-hmm. What we're also seeing in our jail population is a lot of combination meth and opiates together.